Hey guys, can you see me? Can you hear me? If so, say me hi. Apologies for my voice, it's kind of gone. So, how is your NEET PG prep going? I hope it's going on full swing. Just let's discuss few questions in the previous couple of years of NEET PG. So, I have 3 videos for the upcoming NEET PG in the PW Med channel, the same channel. One is two of them are IBQs, which is a compilation of all the images which has been asked in FMG, NEET PG, and INICT. And this just for the last 3 years of paper, approximately 40-45 questions. Let's discuss it quickly and let's get away with it, right? Hello, Victorious me. Hope you are doing good as well. Just give me a second. Okay, I want you guys to answer quickly, fastest finger first. Let's go faster. I don't want to waste your precious time. The right answer and few words why the right answer and maybe a leading questions for that, and then we'll go to the next question, right? Okay, that's the first question. Read the question. Imagine this like an exam. Read it quickly and tell me whatever comes to your mind first. A 69-year-old came with cough, weight loss. He was diagnosed to have a squamous cell carcinoma on bronchoscopy. The resected specimen has a hilar lymph node which shows a brown color pigment. What's the likely pigment to be? Right? So the patient has a squamous cell carcinoma. So first of all, don't be overexcited and write melanin. It's unlikely to be melanoma here. Good evening, Dr. Jain. Right? And it's unlikely to be lipochrome. Lipochrome, or the other name is lipofuscin. This pigment is pretty common in liver, in spleen, in lungs. It's not common, it's not, and maybe pancreas. It's not common in a lymph node. And by the way, it's not black in color, it's brown in color, right? So the black color is a clue here. If something is microscopically black color, there's only one possibility, like Jane said, it has to be an anthracotic pigment, right? Since we are talking about a microscopic black color, I want to give a leading question. This came in an old NEET exam. I want you to tell me the right answer. There's one more pigment which can be completely black in color, which can be seen in liver biopsy. In a case of hereditary jaundice, what's the diagnosis? Microscopy, you see a black pigment in a liver in case of an hereditary jaundice. Think of Dubin-Johnson syndrome. This can come in an answer, right? So this is, again, this is a very unspecific pigment, non-specific pigment. It's the black pigment, black liver also diagnosis of going to be Dubin-Johnson syndrome. Rest everywhere in the part of the body, black means is equal to cold, be it lung, be it hilar lymph node, anywhere near the oral cavity, fine? Let's go to the next question. Read the question. I want you guys to comment on the right answer. Whatever comes to your mind, comment on it. It's the last thing. It's fine to make a mistake here so that you don't make the mistake in the real exam. 40-year-old OPD department with migratory arthritis. Examination had a pansystolic murmur. Borodin, Mason solution, can you rephrase the question? Yes, there's a classical history of an rheumatic heart disease. So rheumatic heart disease, what you see in microscopy has to be an Ashraf body, right? So this entire collection is Ashraf body. Ashraf body, what type of necrosis do you see in Ashraf body? Can you guys comment? That was also previous PYQ. You see fibrinoid necrosis. Remember, fibrinoid necrosis is something which is seen in every vessel wall necrosis, and heart is considered to be the biggest vessel or the largest vessel. So in heart necrosis also I'll have fibrinoid necrosis by default, right? Ashraf body is nothing but it's a collection of macrophages. You see nothing but it's a collection of macrophages. You see them in the myocardium or the junction of myocardium, or also in the valve. We can see Ashraf body is fine. Okay, great. Just one more question. What do you guys call a rheumatic heart disease induced vegetation? There's one more name for that. What is the vegetation? What's the vegetation of rheumatic heart disease called as? It's called as verrucae, right? So verrucae, because they are very, very tiny, less than 5 millimeter vegetation, which can be seen in rheumatic heart disease, warty vegetations or verrucae, right? So rheumatic heart vegetations, I want everyone to answer this question. Is it infective or sterile? Because somewhere you might get wrong, because in cardiac chapter, vegetation is a very important MCQ point, fine? It has to be sterile. Please don't overthink and write it's related to streptococcus. It is always sterile. The only vegetation which is infective endocarditis. The only vegetation which can cause destruction of the valve is infective endocarditis, and the only vegetation which can undergo embolus is infective endocarditis. Rest everything, nothing will destroy the valve and nothing is infective, right? Okay, let's go to the next question. A big question and a very simple answer. Okay, Borodin, the artifactual staining is formalin, right? So if it's a black color, if it's artifact, we have an artifact called as a formalin artifact that can also be black in color. It's due to the formaldehyde which use of preservative. Fine. Okay. Jashan has gone with D. Anyone else wants to add to it? 29-year-old, fatigue for the past 1 year, examination has a massive splenomegaly, and so many questions, pointers are in the total leukocyte count. One is my TLC is elevated, that's a classical finding, and one more classical finding is basophil. Basophil of 7%, you have only one diagnosis, which is CML. That can be nothing other than CML when you have such a heavy basophilia, be it an MCQ or in a real life. The question is very simple. What's the most sensitive? I want to add few more options here. If it's more sensitive, or be it more specific, or be it next line of investigation. So for all the thing, I want you to have the same answer. It's D. Doesn't change. Next line or sensitive or specific, diagnosis is going to be your same, FISH or PCR. Immunophenotyping is not helpful in CML. We don't do your IHCs in CML. Lab score in real life, it's not useful. But can anyone tell me where is lab score useful? Lab score helps me to differentiate leukemioid reaction versus leukemia or versus CML, right? That's where it can help me to differentiate leukemia-like reaction, which can be seen in sepsis. Again, just a leading question. This is a theoretical question, is not useful in real life, right? In sepsis or in leukemioid reaction, lab score will be elevated or reduced. And flow cytometry, by the way, is also not useful in CML. Lab score will undoubtedly be elevated, right? In CML or sepsis, it might, in CML or in leukemia, it might be 0 or it might be reduced. In leukemia reaction, obviously it has to be elevated, right? Just a quick recall, since we are in CML, what is the investigation of choice for almost every acute leukemia? Can anyone tell me one investigation of choice for acute leukemias? Be it an AML, be it an ALL. What will be the investigation of choice? It always has to be flow cytometry, fine? So for all leukemia, except CML, diagnosis answers flow cytometry, right? Be it an acute lymphoid leukemia, acute myeloid leukemia, or even a CLL, chronic lymphoid leukemia, I'm going to do a flow cytometry, right? Otherwise, we are going to do it, in case of a CML, we do a FISH or a PCR, fine? What will be the investigation of choice for any lymphoma? If there's a lymphoma, be it Hodgkin's or not Hodgkin's, what will be the investigation of choice? Anyone? Thirumagal, Jashan, Dr. Jain, Borodin. Make mistakes here, it's fine. Don't be hesitant that I'm going to make mistake here. It's fine. Don't make mistake in the main exam. It's always biopsy and IHC. You cannot diagnose any lymphoma without biopsy or CD markers. That will be the investigation of choice. IHC or CD markers, right? Again, a previous question. What is the color? Brown color is due to in IHC. In IHC, brown is positive. What was it? It is diaminobenzene. DAP is a stain which gave brown color to your immunohistochemistry positivity, right? Perfect. Okay, next question. A girl with a short stature, web neck, thick calves, shield-shaped chest, swelling of the ankle and increased carrying angle. The likely diagnosis? That's a simple answer, right? It's option B. That's a classical picture of Turner syndrome. Turner's, few important pointers about Turner's. What's the most common monosomy alive? Turner's is undoubtedly the most common monosomy alive. Okay, so every other monosomy dies inside the uterus. The only monosomy which is alive is Turner syndrome. And Turner syndrome, what's the most common symptom of Turner syndrome? Perfect, it's 45XO or 45X, whatever it is. Most common symptom is short stature. Like close to 95 to 100% of the Turner's babies will be short. And obviously primary and amenorrhea could also be the presenting feature. But first thing, clinical thing is obviously short stature. Good evening, Rahul. Right? Turner syndrome will have streak ovaries. Okay, that's a classical finding. Turner syndrome can have mosaics also. It's not only clear-cut Turner's. I can have normal as well as abnormal karyotyping in patients with Turner syndrome. Fine. Okay. One more thing. What can anyone tell me? What will be the genotype of Klinefelter syndrome? Whatever comes to your mind. Klinefelter syndrome genotype. It has to be 47XXY predominantly or XYY, right? So, or XYY, right? So 47 chromosome. It's one like a trisomy of an 6 chromosomes, right? 47XXY is the common thing for your Klinefelter syndrome. Fine. Okay. Next question. I'm not going with Downs because everyone knows Downs. A patient with a chronic occupational exposure of benzene, repeated infections, EC fatigability, weight loss, evening rise of temperature, right? Dr. Jain, yes, bang on, it's classically leukemia. Perfect. There was a confusion when this question came during the recall session. People said that it's not benzene, it's benzidine. If it's benzidine, what cancer will it cause? If it's benzidine instead of benzidine or aniline dyes causes bladder cancer, and benzene causes leukemia, right? But I don't want you to go with this for the only reason it's a fact. Fact is very difficult to remember, right? I want you to go with this. Patient with a repeated infection, EC fatigability. Can I say this? Cytopenias, reduced WBC, reduced hemoglobin? Yes. Which of these four can cause cytopenia? There's only one which can cause cytopenia, which is leukemia. Go with the history, not with the fact, because fact is very, very difficult to remember. Now it might look easy, right? When you sit in the exam hall with 19 subjects facts coming inside, it's very, very difficult. Go with the history, that's much more easy. So if it is a bladder cancer, what could be the history? What could be history with a bladder cancer? Bladder cancer is classical. You'll have a terminal painless hematuria, right? So painless hematuria is a classical finding for bladder cancer. That's how you're going to diagnose bladder carcinomas. Yes, benzidine could be an extra added point. It cannot exclude history at any point of time, right? Perfect, amazing. Okay. In case of iron deficiency anemia, which of the following is increased? Hello Lalit, how are you? In case of iron deficiency anemia, which of the following parameters is increased? TIBC is definitely elevated, right? So this reduce, this reduce, this reduce. I hope you know the relation. Your serum iron and transference saturation is directly proportional always. Reduced iron, reduced saturation. Serum ferritin is always inversely proportional to your TIBC. If ferritin is reduced, TIBC will be elevated by default, right? So here TIBC is the only one which will be elevated, rest everything will be reduced, right? Iron profile is important. It's been repeated quite some time. Remember this, you can use the same iron profile for your iron deficiency anemia, hemochromatosis, whatever iron metabolism you take, you can take care of that, fine? Okay, next. This was asked once, it is not repeated after that, but if it's asked again, you should be able to know. Which of the following is a prognostic marker for a multiple myeloma? Yes, Lalit, this is for upcoming NEET PG students. So like regular class, we'll do in the other channel, right? Perfect. So beta 2 microglobin, right? This is based on a prognostic system called as an IPSS. IPSS is standard international prognostic system for almost every hematological tumors. I don't want undergraduates to go into it. If this repeats, think about it. And also remember, beta 2 microglobin will be altered in almost any condition with renal failure. That's why it's indirectly related to multiple myeloma prognosis, right? One of the common organs which can undergo failure in case of multiple myeloma is definitely your kidney, right? So that's why it's related with multiple myeloma. Again, since it's beta 2 microglobin, kidney is always related. Can I also say what's the type of amyloidosis deposit you see in case of an chronic hemodialysis? Same, right? So same, I have A beta 2 or A beta 2 microglobin, which is seen in case of a chronic hemodialysis. So beta 2 microglobin is almost always related to kidney. Do remember that, fine? Okay, perfect. Since we have A beta 2, can anyone tell me where do you see A beta? A beta amyloid? A beta is in Alzheimer's disease. Great. Can anyone tell me where do you see 𝐒𝐿? Brain and Alzheimer's, obviously. 𝐒𝐿 seen in case of thyroid and your medullary carcinoma thyroid. Can anyone tell me where do you see AIAPP? AIAPP stands for islet amyloid polypeptide. Where do you see that? You see them in pancreas. I'll tell the organ, you tell me the condition. Two conditions do remember. One, type 2 diabetes, not type 1. It will not be seen in type 1, it will be seen only in type 2. And also the tumor, insulinoma. Okay. When you have a tumor of the beta cells of pancreas, you will see them as well, right? Insulinoma. Fine. Great. Let's go to the next. Answer. A pap smear, patient involving hyperchromatic nuclei. Okay, Prajapati, it's not metaplasia. Anyone else? See, whenever you see this pointers, right? Irregular nuclear borders, low maturation index, and hyperchromasia, whole thickness, it has to be dysplastic. The only thing it's not saying it's cancerous. It did not breach the basement membrane, right? Since it's not breaching the basement membrane, it's not carcinoma. It cannot be metaplasia or hyperplasia because these both will not have all these abnormal characters, right? Just an add-on point. Can anyone tell me what type of CAN it will be? Since cervical thing, CAN 1, 2 or 3? Himani, anaplasia is an abnormal differentiation. Yes, I can put them as anaplasia as well if I have to put in a single line. It is CAN3, or the other name is carcinoma in situ because you have whole thickness. If the entire thickness is involved, it has to be CAN3 and not CAN1 or an carcinoma in situ, right? Perfect. So previously we had CAN1, 2 and 3. Nowadays we don't have CAN1, 2 and 3. We have reclassified them into L-cell and H-cell. L-cell is low-grade squamous intraepithelial lesion. H-cell is high-grade squamous intraepithelial lesion. Under H-cell, you have both CAN2 and 3. Under L-cell, you have CAN1, right? That's how it is, fine. We don't have CAN anymore, but if any old question comes, do remember CAN1 is reversible, L-cell is reversible, H-cell is irreversible, so we have to do an operative management. That's a basic difference of dividing them into low-grade and high-grade, fine. Okay, just few more questions. It's on pap smear. What's a fixative for pap smear? Pap smear, fixative. There's only one fixative. I don't want you to remember any other fixative. It's absolute alcohol. 100% alcohol is a fixative. That's what we use. Ether is not being used because ether is inflammable. We don't use it. It's just only absolute alcohol or spirit, right? That's all it is, right? Ethyl alcohol 100% or an absolute alcohol, right? Pap smear has two methods. One is based on something called an conventional pap smear. Conventional pap smear is what you must have seen in your hospitals using the IR spatula, and you have something called an LBC. LBC came again once in an exam with a round circle. If you have a slide and a circle, that's called as an LBC, which is called as a liquid-based preparation, which is based on centrifugation. Since it's centrifuged, you have the circle. Otherwise, a normal pap smear, the pap smear looks like a tongue, like normal smear what you take, right? Perfect, amazing. Thin prep is that trade name for LBC, fine? Okay. Okay, next question. First tell me the diagnosis, then let's go to the next. It's diagnosed Turner's, classical finding of Turner's. We saw this Turner's features before itself. It's your bilateral streak ovaries. Turner's had a mnemonic. I'm sure you must have seen Turner's babies when you go to a circus or any sort of that. Tiny kids who perform in circus most likely will be Turner's, like clowns, right? God forbid, but like clowns. C for the cystic hygroma or the web neck or the congenital heart disease. L for the low hairline and the low thyroid. O for this ovaries being streaked. W again for the web neck, the cystic hygroma. That's there in the question. N for your nipples being widely spaced. Nipples being widely spaced. That's not the primary problem of the nipple. It's the problem of the chest. The chest wall becomes like a shield. So the nipples becomes widely spaced. And S for your short stature. And there's a very specific finding in Turner's, the fourth metacarpal. What happens to fourth metacarpal in case of Turner's? What happens to fourth metacarpal in case of Turner's? It will become shorter. Exactly short fourth metacarpal. So I can have an X-ray finding and a short kid. I can correlate and ask a question, right? Short fourth metacarpal is very, very characteristic of Turner syndromes, right? Okay, next question. Tell me what's your answer. A. Okay. Why A? Fine, let's read through the question. Okay, fine. A 21-year-old trainee, outpatient department, bleeding gums, fever for the past 2 months, shows pallor, right? And hemoglobin is 3.1, TLC is 1600, platelet is 14,500. Can I say this is pancytopenia? Right? Definitely this is pancytopenia by default, fine. So I can rule out tuberculosis. Tuberculosis is very unlikely to have pancytopenia. We can rule that out, fine. Okay. Now my reticulocyte count is 0.5. If reticulocyte count is 0.5, the bone marrow is functioning or not functioning? It's a very high retic or low retic? It's a very low reticulocyte count, right? 1 to 1.5 is normal. 0.5 is very low reticulocyte count, which means bone marrow is not functioning. If the bone marrow is not functioning, I can rule out PNH because PNH is an hemolytic anemia. What happens to reticulocyte count in case of an hemolytic anemia? I'll have elevated retic, right? By default, my bone marrow will respond. Any hemolytic anemia, elevated reticulocyte count will be there, so I can rule it out, right? Now let's go to myelodysplastic syndrome or an idiopathic acquired aplastic anemia, fine. So to call something as myelodysplastic syndrome, what should I see in the microscope? Should I see dysplasia? Bone marrow examination shows fat, absent megakaryocytes, and few immature cells. Is there any dysplasia mentioned here? There's no dysplasia, so it's very, very unlikely. Again, MDS might not have exactly pancytopenia. It can have bicytopenia, but MDS should have dysplasia. If there's no dysplasia, I cannot call it a myelodysplastic syndrome. It cannot be myelodysplastic syndrome, right? So the answer is idiopathic acquired aplastic anemia, not a myelodysplastic syndrome. Reason, pancytopenia, bone marrow is not functioning, and bone marrow has fat. If it's bone marrow replaced by fat, only one diagnosis, aplastic anemia. Fine. Okay, let's go to the next. Next. Right answer. One of us has gone with B. Anyone else? B, B, B. Great. So it's very simple. Purpura, abdomen pain, joint pain, and hematuria. This is most likely due to IgA nephropathy. That's a component of 𝐒𝐄𝐝 and purpura, right? As a classical diagnosis, IgA nephropathy and 𝐒𝐄𝐝 and purpura, right? Just one more question. Since we are in this topic, what type of purpura will be this? Palpable or non-palpable? Because purpura is a very important history, and this might help you differentiating some things down the road. I have two types of purpura. One is palpable purpura, other one is non-palpable purpura. If the purpura is palpable, I want you to think of vasculitis as the cause, because purpura can also be due to thrombocytopenia, right? So if it's due to thrombocytopenia, the purpura will not be palpable. It's a hematological cause, no palpable. If it's a vascular cause, we'll have palpable purpura, right? That can help you to differentiate if at all you are stuck with purpura as a differential diagnosis, fine? Perfect, great. Next question. A 49-year-old came to the OPD with fatigue, tiredness, cervical lymphadenopathy. TLC and DLC were normal, no immature cells. Lymph node biopsy taken. Diffuse effacement. This is a very important point. Whenever you see diffuse effacement, it's lymphoma by default, right? And architecture gone, everything gone, and I have BCL2 positive. That's what is second important thing for me. BCL2 positive, my diagnosis has to be only one, your follicular lymphoma, right? CD markers, you must have read about multiple CD markers, but I'm going to write characteristic CD markers. I want you to tell what will be your diagnosis, right? First here, BCL2 positive, by default follicular lymphoma, right? Okay. CD5 positive, 23 positive, diagnosis. Both of them are positive, you think of CLL. Okay, I'm going to talk about only one important marker here, not everything. Your cyclin D1 positive, what do you think of? Cyclin D1 has only one answer, it is mantle, right? Perfect. I'm sure you know the other leading question. Cyclin D1 negative mantle, what is positive? AIMS asked once, after that they didn't ask, and no, it's never getting repeated, right? SOX11 is positive, if it's cyclin D1 negative mantle, right? Perfect. CD43 positive. If you see any question which says CD43 positive, think of a marginal zone lymphoma. Okay, that's diagnostic for CD43 being positive. If you have a question which says your CMYC is positive, what do you think of? CMYC is positive when only one tumor, has to be the King Burkitt. It's Burkitt's lymphoma, right? Just one marker. And like in our question, if BCL2 is positive, I want you to think of only one thing, has to be a follicular lymphoma, right? These are one characteristic IHC marker. If ALK1 is positive, what's a marker you think of? What's a tumor you think of? ALK1. ALK stands for anaplastic lymphoma kinase. It's positive in a tumor called as ALCL, anaplastic large cell lymphoma, right? So these are few things, and obviously we cannot ignore this. 15 positive, 30 positive diagnosis. 1530 has to be your Hodgkin's lymphoma, right? Classical Hodgkin's lymphoma to be specific. NLPHL will be 1530 negative, 2045 positive, right? Perfect. Okay. These are few markers which I want you to remember. Maybe after the lecture, take a screenshot of this. See it the day before the exam. This is very, very important. Fine. Okay, let's go to the next answer. What comes to your mind? It's a very simple thing, right? The classical macrocytic megaloblastic anemia here. Answer has to be a folic acid deficiency. When you see 120 femtoliters, extremely high MCV, macrocytic or megaloblastic possibilities, two things, B12 and folate. B12, if the history says vegan diet, go for B12. If the history says no fruits, go for your folic acid, because folic acid is available in multiple food resources, but all of them will be destroyed because folic acid is heat labile. It's present in meat, it's present in milk, but it will be destroyed. The only richest source of folic acid is fruit. If you stop eating fruits, that's a question here, very less fruits, you will not have enough folic acid by default, right? Any fruit, like as simple as banana is good enough for us, but it should be there in the diet. And a vegan diet, no milk, no animal protein, definitely there's a chance of B12 deficiency, right? Okay, next. Chronic alcoholic, examination shifting dullness in the liver is less than 7 centimeter. It's kind of cirrhotic. Histopathological examination reveals so many things. So can anyone tell me what this means? You guys told the answer. The answer is undoubtedly intermediate filaments. What is the inclusion body what you're talking about here? Hello, Dr. Anis. Perfect, right? That's your Mallory-Denk bodies, or the older name Mallory-Hyland bodies, right? Mallory-Denk or Mallory-Hyland. Mallory-Denk is nothing but CK8 bar CK18. They are destroyed CK8 and CK18, right? Perfect, Himani. So CK or cytokeratin is nothing but a component of your intermediate filament. Cytokeratin is an intermediate filament. There's one more intermediate filament called as 𝐌𝐿. 𝐌𝐿 is also an intermediate filament. Where do you see this? Which cell you can see 𝐌𝐿? Cytokeratin is seen in epithelial tissue. Where do you see 𝐌𝐿? 𝐌𝐿 is seen in every, yes, mesenchymal origin. Could be a sarcoma, could be an any benign mesenchymal tumor. I will see that. That's all right. There's one more intermediate filament called as GFAP. This also is an intermediate filament. Where do you see this? So I can ask multiple things in the same intermediate filament category, right? GFAP is seen in case of glial tumors, right? Pilocytic is right, astro is right. Any glial tumor, I will see them. Glial, fibrillary, acid protein, I can see them, right? All of these come under intermediate filaments only. Fine, perfect, amazing. Next question. Answer. A 59-year-old diagnosed with pure red cell aplasia and a medial cell mass. Has to be thymoma. Can anyone tell me one more classical paraneoplastic syndrome seen in thymoma, which is seen with the big B? The one more classical paraneoplastic syndrome is myasthenia gravis. Okay, myasthenia gravis is also very common in case of a patient with thymoma. Do remember, both of them are classical for thymoma. Sorry. Okay. So since we are with pure red cell aplasia, PRCA, few words regarding PRCA. Tell me one virus which can cause PRCA. PRCA is the other name for pure red cell aplasia. Any one virus which causes PRCA. Your parvovirus B19 can cause PRCA. Fine. Parvovirus B19 actually affects one of the important precursor cell in the bone marrow. What cell is that? This also came once in FMG exam. Parvovirus infects proerythroblast. They infect the proerythroblast, and the point of entry for parvovirus is an antigen called as P antigen. So via the P antigen, it goes into the proerythroblast and destroys the proerythroblast. So once it's destroyed, it will not be able to produce RBC, right? Himani has opened up one more question. Can anyone tell me which is the virus which takes CD31 as the entry point? Or the other name for CD21 is CR2. It's your Epstein-Barr virus, right? Epstein-Barr virus, the entry point is CD31. Parvovirus, the entry point is your P antigen. Perfect. In Epstein-Barr virus, can anyone tell me the characteristic peripheral smear finding I see in case of an infectious mononucleosis? There's a Peripheral smear finding, one name cell called as a downy cell or your ballerina skirt appearance, right? Okay. Just to complete this downy cell or ballerina skirt appearance, tell me this downy cell is a reactive lymphocyte. Is it a B lymphocyte or a T lymphocyte? Is it a B lymphocyte or a T lymphocyte? Downy is not a B lymphocyte. Downy is a T cell. Okay. EBV infects B cell. To destroy the EBV, the T cell comes. That's your downy cell, right? Be clear on this. EBV will infect the B lymphocyte, and this is a protective thing my body's response, which is a T cell here, fine. And here my answer is thymoma. Okay, great, great. Next. If you have questions like this, don't think they're easy. Please read all the options carefully and go with it. Answer. Simple one, right? It might look easy. Options are long. It's easy only. It's not difficult, but options are long. We just need a little bit of patience. Decreased telomere length is definitely associated with aging, right? What's the enzyme which will stop this? We have enzyme which is telomerase. Okay, a few words regarding telomerase. Can anyone tell me? Shika, that was this year recall, right? I need to know the options. I think Dr. Mamta has clearly described that in this PYQ recall of iron CD. Just go and have a look at that. Fine. Telomerase is the enzyme. Telomerase, the maximum quantity of telomerase is seen in case of germ cells. Okay, that came once in an exam. What's the theory? Who coined the term telomere and telomerase? The person is called Hayflick. Hayflick is the person who said that, okay, every cell will die within some point of time. He is the person who entirely conceptualized the telomere shortening and everything. Fine. So telomere is a very simple concept. You must have read in biochemistry. Just recall of that. Okay. Next. Answer. Okay. So Ha has gone with B. Anyone else? Magna has gone with B. D. Why D? B, right? So it's simple. See, whenever you have electrophoresis, right? I have a few clue for you to know what will be the most likely answer for electrophoresis. It's very simple. Whenever you see F in adequate quantity, it's a severe hemolytic anemia. Just remember this. It's a severe hemolytic anemia. Whenever you see A2, think of a thalassemia. I'm not saying it's always thalassemia. Think of a thalassemia. This is a shortcut. This is not the routine one, right? So now let's say I'm having a question which says hemoglobin A is present, A2 is present. What will be a diagnosis? What will be a diagnosis? Thal major, thal minor. It has to be thal minor, right? Because it's no F, so not severe, and A2 is present, so it's a thalassemia, right? Let's say I have hemoglobin A, hemoglobin S, both are present, right? So what do you think of? If you see both hemoglobin A and hemoglobin S, so sickle cell anemia or sickle cell trait? Homozygous or heterozygous? This is your trait again, right? It's a sickle cell trait. When I say hemoglobin A2 is present, hemoglobin F is present, only these two possibilities. Possibilities, only A2 and F in significant quantity. This possibility is your thal major, right? Most likely thal major. Fine. Okay, Borodin A2 unlikely to be seen in neonate, and I'm not going to give a normal neonate hemoglobin electrophoresis, right? Okay. So if I see hemoglobin F and hemoglobin S, possibilities, no A. Possibilities. This is sickle major or sickle homozygous. Okay. So sickle homozygous, sickle cell anemia. So please do remember, if A2 is present, think of thalassemia. If F is present in significant quantities, always a major hemolytic anemia, right? So here I have S spike. So by default, I have to go to your sickle cell disease. Fine. Okay. It's not beta thalassemia. It cannot be beta because of S. Fine. Okay. Next question. Warburg, my favorite part. It's simple. Warburg is nothing but it forms metabolic intermediates which are needed for cell growth and multiplication. That's the classical definition of Warburg's effect, right? A very old PYQ. What happens in Warburg's effect? Aerobic glycolysis or anaerobic glycolysis? In Warburg's effect, there are few more PYQs which happen before. It is aerobic glycolysis. Please do remember, though the end product is lactate. Lactate is the end product of your Warburg's effect. It's aerobic glycolysis, not anaerobic, right? What is the one classical gene which controls your Warburg's effect? Warburg is aerobic, not anaerobic. Warburg's, it is your MYC gene, right? And it's one important thing which leads to Warburg's effect is mitophagy. Mitophagy is a new concept which happens in cancers. Cancer cells kind of eat selectively the mitochondria alone. That's why Warburg is not, that's why the cells are not able to do the Krebs cycle and the electron transport chain, stops at aerobic glycolysis and converts every nitrogen product into the production of your DNA and RNA, fine? Okay, next. Possibilities, answer. I'll zoom the image a little bit after I've read the question. Samantha, mitophagy is selective eating of the mitochondria. There's this thing here which I want you to look at. This one, this one, this one, this one. These are all tiny broken RBCs, right? So these are all broken RBCs. That's nothing but your histiocytes. Now tell me, in which of the following condition you will see histiocytes or broken RBCs? Histiocytes are classically seen in case of an MAHA, right? Helmet cell or a histiocyte, perfect, Imani, right? You will see them in microangiopathic hemolytic anemia. So microangiopathic hemolytic anemia, one of the classical pointers here is your mechanical second heart sound. Whenever you see hand, prosthetic heart valve, right? A prosthetic heart valve patients will have your hemolysis because the heart valve is a metallic heart valve. It goes and hits a mechanical valve or a mechanical heart sound. You will have MAHA. Then might be a bit of difficult question if you're not able to relate it, right? Like Doc said, the RBC will be crushed and destroyed. So we have the broken RBCs here, right? Perfect, great. Next question. Which of the following is false regarding your NET? Which is false regarding NET? NET, it's not about the mitochondrial DNA, it's about the nuclear DNA, right? Nothing, Lalit. Since this for NEET PG audience, let's me concentrate on that. That's all, fine. We'll definitely discuss more about pathology and medicine in the other channel. Okay. So NET is neutrophilic extracellular trapping, where the WBCs undergo lysis. It's definitely commonly seen in sepsis. It's produced in response to the bacterial infection. That's nothing but the sepsis. The chromatin with the antimicrobial enzyme will form a trap where all the organisms come and get trapped and they'll be destroyed, right? I won't see the mitochondrial DNA. Yes, nuclear DNA might be out, but not the mitochondrial DNA, right? Okay, there's one more name for NET. We also call them a beneficial suicide of neutrophils. The neutrophils die just to counteract or stop the organism from invading or destroying the human body. Can I tell one of the disadvantage of NET will be organ damage? Yes, by default, the host tissue will be damaged. NET is the only thing which results in ARDS in case of pneumonia and in case of a sepsis. Fine. Okay, next. Diagnosis. Yes, Tarun, right. Might be a difficult one. Read the question. A clue is here. Multiple yellow white plaques in the trigone of bladder. That's the clue here. You are amazing. You look at this, you look at your malakoplakia. Now, can anyone tell me what I'm seeing in the microscopy? There's a named finding here in the microscopy. What is the diagnosis? I'll zoom the image here. So these are the structures which are important for me here. I have very classical calcific deposits, right? Perfect. That's your Michaelis-Guttman bodies. Michaelis-Guttman bodies are nothing but calcific macrophages. Their calcification inside the macrophages Because in case of a malakoplakia, what is malakoplakia? I'll definitely explain. Malakoplakia is nothing but a chronic inflammation of the bladder where the macrophage fails to remove the organism. It's simple E. coli infection, that's all. So if E. coli infection is not be removed, macrophage cannot act. What's the treatment? I give antibiotics, that's it. Right? So the macrophage fails to remove them. So macrophage accumulates all the dead debris and has calcification. That's your Michaelis Menten body, right? It's a form of chronic interstitial cystitis, right? Okay, great. Perfect. Yes, so ask. Next question. Answer? COVID had few questions which came during the season of COVID. We'll look at it soon. I hope they won't ask any more questions in COVID. Always the outcome of COVID or any acute lung problem is this. That's your hyaline membrane. I'm kind of rephrasing the hyaline membrane here. Think layer of fibrin lining the alveoli. That's what I also see in almost every case of ARDS, right? Next question. Be it beyond ARDS or based on COVID-19. Tell me what's the starting point? What will trigger ARDS or what will trigger COVID-19 induced damage? Epithelial damage or endothelial damage? Twice it was asked, one as a theory part and one electron microscopic image of a vessel was asked and they pointed that out. COVID or ARDS, the starting point is always endothelial damage and not pulmonary epithelial damage. Pulmonary epithelium is the effect. The starting point is always an endothelial damage, right? So if you have an electron microscopic image of a vessel and the endothelium is marked, please have a look at that as well. This was also asked once in COVID, fine? Perfect, great. Next. What's the right answer? When this question came, quite a few of your seniors wrote the wrong answer. Let's see how many of you tell me the right answer. The most important thing here is your diagnosis. What's the diagnosis here? See, because if you superficially look, the question seems very simple. Hemoglobin of 9 gram per deciliter, MCV of 60. First thing every doctor is going to think about is an iron deficiency anemia, right? By default, you look at iron deficiency anemia, but the answer is not iron deficiency anemia here because of this. RBC count is 5.2. If RBC count is very high, what happens? It's hemolytic anemia or a nutritional anemia. RBC 4.5 to 5 is normal, right? Now it's 5.2. If RBC count is high, this indicates the bone marrow is responsive. When the bone marrow is responsive, it cannot be IDA. It has to be hemolytic. Okay. So why this question was given is for you to calculate Menster's index. I hope you remember the Menster's index, right? Calculate Menster's index and then come to the answer here. Now the diagnosis here is not your iron deficiency anemia. It's your Thal minor. Okay. So it's a Thal minor. So Thal minor is the diagnosis here. So if it's Thal minor, now tell me which of the following investigation will be the best for the patient. Do I require serum ferritin levels here? Harshad, I'm just going with a mixed bag of maybe 4 years approx. I don't want a ferritin level in case of a Thal minor especially. I would want HbA2 levels. I might require ferritin for a Thal major because in Thal major I can have secondary hemosiderosis, right? But not in Thal minor. So please, if you have a very simple question, don't overlook. This was asked once in a NEET exam and most of your seniors overlooked and everyone will think of an iron deficiency anemia only, right? But please look at our RBC count or your RDW. If RDW is given, if RDW is wide, what do you think is the diagnosis? Thalassemia or iron deficiency anemia? It's iron deficiency anemia, right? Think about that. And if your Menster's index, these are two things which we look for, right? The Menster's index is less than 13 or more than 13 IDA. What happens in IDA? Menster's index less than 13 or more than 13? In IDA, it has to be lower the denominator, it has to be more than 13, right? More than 13, IDA, RDW wide, think of an IDA. Please then come to the answer because you might slip here, fine? Okay, great. Next question. It's a simple one. 60-year-old man brought to with dragging pain in the abdomen. On examination, there's a massive splenomegaly, leukocytosis and melanocytes, basophils, metamyelocytes, everything are there, right? Samantha, that's just formula used. I can do both HbA2 in both HPLC as well as in hemoglobin electrophoresis. Specific is obviously HPLC, right? There's diagnosis of it. CML and 922 is the diagnosis, right? Same history, elderly person, massively enlarged spleen. These are the clues, right? I have an elevated TLC count. I think of CML, fine. When I have an pancytopenia, same history, elderly person, massive spleen, pancytopenia. What's the diagnosis? I want you to look from the history itself. What's the diagnosis? Classical history of hairy cell leukemia, right? Perfect. If it's hairy cell leukemia, can anyone tell me what is maybe one or two markers which you look for? We have one specific marker. I want that also, and also one histochemistry marker. Hairy cell leukemia, look for TRAP, tartrate resistant acid phosphatase is positive 1, right? And also I have a marker called as an annexin, right? Annexin is also an important marker for an hairy cell leukemia, right? Perfect. Can anyone tell me what is the gene which is classically mutated in case of hairy cell leukemia? 103 is also a good marker, 25 is a good marker, but I would say annexin A1 is a much better marker than others, right? Which gene is mutated in hairy cell leukemia? This is also asked. That's BRAF. BRAF is classically mutated, right? BRAF V600E, right? Amazing. Look at the history. Just don't write CML if you see massive splenomegaly. Follow it up. If it's leukocytosis, basophilia, your CML, pancytopenia, monocytopenia, think of an hairy cell leukemia, right? Perfect. Next question. Answer. What is this guy who's sitting there inside the blast? You can see it. Tiny OR rod, right? Perfect. Now tell me, if I see OR rod is diagnostic of your acute myeloid leukemia. What's the only genotype here which is diagnostic of an acute myeloid leukemia? There's only one where I can, which I can see in acute myeloid leukemia is your 1517. Though in 1517, you will see one OR rod or multiple OR rods. 1517 la multiple OR rods. What's the cell we call it? In case of 1517 translocation, we call it faggot cell, right? Faggot cell is a cell with multiple bundles of OR rods as a classical finding, and you have your buttock-shaped nuclei. That's also a classical finding seen in case of an APML or your translocation 1517 associated leukemias, fine? Okay. Now, I want you to tell me few more related questions here. To call it an acute leukemia, what is the cutoff blast criteria? If you have so many blasts, I look for one. Think of an acute myeloid leukemia. What's the cutoff? I need to have more than or equal to 20%. If you have more than or equal to 20%, I think of an acute myeloid leukemia by default, right? So there are few exceptions where I don't want this 20% criteria. What are the exceptions? Exceptions are always MCQs. Which all translocations, if they are there, I don't want this 20%. One is your translocation 1517. If 1517 is there, I don't want 20%. Perfect. Inversion 16, if it is there, I don't want the 20%. Other one, translocation 821. Perfect, Bhavesh. Okay. So these three, 821, 1517, inversion 16. If you have any one of these three, I don't want the 20% criteria. I will still call it an acute leukemia. Okay. Just one word before leaving this. Translocation 1517 induced APML. What's the treatment? Can anyone tell me what's the treatment for APML? Treatment? It's ATRA, right? All-trans-retinoic acid. And one more classical finding for APML. APML, don't forget this. There's a only leukemia where it is CD34 negative. Rest, every leukemia will be positive for CD34, the marker. There's a only leukemia where CD34 will be negative in case of an APML. Fine. Next question. So, spotter. Now you look at this question. There's one classical point which I want you to look for. Then automatically you can tell the answer. First, tell me what's the diagnosis here. Then we will go to the answer. Diagnosis: Undoubtedly CLL, because I have smudge cells, right? So when I have smudge cells, I think of a CLL, and any leukemia except for CML, my investigation of choice has to be flow cytometry. Only for CML, I go for molecular genetics, FISH or a PCR. Every other leukemia, acute or chronic, I go for flow cytometry only. You don't want bone marrow examination for any leukemia if you have flow. Fine, do remember that. Okay. Next, so the spotter. There are two clues here. The first clue is this: swelling in the jaw. Swelling in the jaw, it's a leukemia or lymphoma. What is it? There's only one guy, Burkitt's lymphoma. Second, there's a Burkitt's blast where you have these vacuoles. When you have vacuoles in the blast, that's classical for a Burkitt's blast or a Burkitt's lymphoma. Fine. One more clue I'll tell you. This might come very, very handy. If you have any lymphoma in the question, if it's a child, only lymphoma which can happen in children is Burkitt's. Okay. Leukemia in a child, most likely it will be ALL. AML in the child is very, very rare. It has to be ALL by default. Child lymphoma Burkitt's, child leukemia ALL. By default, this is how you have to diagnose. Again, the clue goes 7-year-old jaw swelling has to be there. Whenever you remember Burkitt, you will see an African child with a swelling in the jaw. That's what comes in your mind, right? All are characteristic markers here. Fine. Okay, next. Yes, by Schrodinger's cat, it's L3 blast. The older name was an L3 blast. Now we call it a Burkitt's blast. Owl's eye. Classical owl's eye inclusion has to be in CMV, right? BK virus can also be here because renal transplant can also have BK virus. BK virus will not have an outside inclusion. It will have just a basophilic inclusion, a shiny inclusion, right? So in BK virus, what's a urine microscopic finding called as? We have a urine microscopic finding in BK virus. We call it a decoy cell. Okay, decoy cell can be seen in case of BK virus infection, post renal transplant only in urine microscopy. Fine. And if it's an outside inclusion, it has to be your CMV virus only. CMV can be seen in esophagus. CMV can be seen in your any internal organ, lungs, and also the your kidney on your bladder, post immunosuppressed state. Okay. Possibilities. This came in your recent INICT, a modified version of this. Answer? Prognostic marker, only one guy, it's ER, right? Though other things are required for me, but ER is the most important thing. If it has to be single marker ER, BRCA is not important for me unless it's an inherited cancer, right? 55-year-old, I'm not going to think of an inherited breast cancer, has to be acquired, and ER is one of the most important prognostic signs, right? Diagnosis. Quite a few times they did ask histology also, right? They have asked till now islets of Langerhans histology and this histology. These are your glomerulus, right? So glomerular, just normal glomeruli, right? Lymph node, you have cortex and medulla, Hassel's corpuscles. Which organ do you see this? This is come as an IBQ as well as a theory question. Though it's an anatomy question, just we'll discuss it. You see them in thymus. They will look like your keratin pearl. It's keratin pearl only. It's keratin in the form of a whorl. That's what is you see in thymus. Thymic epithelial cells become like that. We call it Hassel's corpuscles. Thymus, not thyroid. Fine. Okay. Spotter. This is an old question, but still. All these red color actually should be pink in color. All of them are intracytoplasmic inclusion of molluscum, right? Small white papules. One more important clue, umbilicated. If a question says umbilicated pearly white papules, think of molluscum contagiosum by default, right? Like Himani said, it's HP bodies, right? What does HP stand for? There are two HP bodies. What is this? There are two HP bodies which can come in your microbiology. What is the full form of HP here? Henderson-Peterson. Where do you see Halbert-Stader Provazac bodies? Though it's not my domain, where do you see Halbert-Stader Provazac bodies? You see that in chlamydia. Chlamydia also has HP bodies, right? Trachoma, chlamydia trachomatis or chlamydia, you see that HP bodies. Henderson-Peterson is seen as molluscum. Halberstadter provasa is seen as a case of a chlamydia patient. Fine. Next question. Peutz-Jeghers has to be an hematomatous polyp, right? The most common hematomatous polyp, is it Peutz-Jeghers or juvenile polyp? The most common hematomatous polyp is Peutz-Jeghers or juvenile? The most common is not Peutz-Jeghers. The most common is juvenile. Peutz-Jeghers is a bit rare. Juvenile polyp is definitely much more common than a Peutz-Jeghers polyp, right? If the same options are there, which of the 4 options will describe a juvenile polyp? Is it retention, inflammatory, hematomatous, or malignant? If it's juvenile polyp, which of the options will describe a juvenile polyp? Juvenile polyp is a retention polyp, right? Perfect. It's a mucus retention polyp. That's a juvenile polyp. That's how it looks like, right? Okay. Juvenile polyp, what's the most common location? It's also seen in rectum. Okay. And the most common location of Peutz-Jeghers polyp is undoubtedly jejunum. Fine. Okay. These are a few pointers regarding the polyps in this question. Inflammatory polyp, most likely you'll have a history of your either an gastritis or an use of antacids. That will be the case of an inflammatory polyp. Fine. Next. Answer. 55-year-old chronic smoker came to OPD with cough. Patients are supposed to have hypercalcemia. That's an important clue. Eosinophilic cytoplasm and hyperchromasia. All points are towards squamous cell carcinoma, right? Hypercalcemia is one of the commonest paraneoplastic syndrome and it's definitely seen in patients with squamous cell carcinoma, right? Same options. Question says the patient has SAADH. It's the same option, but the patient has SAADH or the patient has Cushing syndrome. What will be the diagnosis? That's the case of small cell carcinoma of lung. So these are few important pointers which I want you to remember regarding squamous and small cell carcinomas. Fine. Amazing. Next question. Answer. Retroperitoneal hematoma with a history of pain and swelling of the knees. Hemarthrosis, retroperitoneal hematoma, always think of factor 8, factor 9, that's hemophilia, right? Hemophilia A and B, because these are classical history of hemophilia. Though I might see them in others also, but I will first think of an hemophilia by default, right? Few things regarding your factors. Factor 12 is always unique. Is it involved in clotting? Yes or no? Hematoma is blood clot, Samantha. Factor 12, is it involved in clotting in vivo? No. It's not involved in vivo clotting. Okay. So factor 12 deficiency, that makes it very unique. So factor 12 deficiency, there'll be no history of bleeding. That's first and the most important thing. And the second thing, what will happen to APTT in this patient? Will it be elevated or reduced? Factor 12. Hegman factor is the other name. It will be elevated. Elevated APTT, no history of bleeding. Think of factor 12 deficiency, right? That's very unique because factor 12 is not involved in clotting cascade at all. Okay, great. Next. This is a simple one, spotter. What's the answer? This is a cell here, smaller, darker, no central pallor. Yes, Samantha. Great. Whenever you see a patient with spherocyte, do not think of hereditary spherocytosis because the most common cause of spherocytosis is always autoimmune hemolytic anemia. By default, it has to be AHA. So I will think of an AHA and do a 𝐒𝐝's test. I will never do an osmotic fragility test unless and until I do a 𝐒𝐝's test. The next step is always 𝐒𝐝's test and always AHA whenever you see spherocyte. And there are many spherocytes in this peer. Whenever you see spherocytes, that's what I'm going to look for. Fine. Okay. HS, I will think of when all these things are negative. There are few pointers regarding HS if you want to know. HS is dominant or recessive? Inheritance. It's an autosomal dominant inheritance, and a HS presents early in life or later in life. Every dominant inheritance by default will present later in life only. Okay. In HS, what's the most common mutation? All these I'm sure you know, right? The most common mutation has to be an ankyrin defect, right? I want to add one more finding here. There's a very severe variant of HS, and which is autosomal recessive, which is alpha spectrin defect. If I have an alpha spectrin mutation, which can be autosomal recessive and which can be a bit of severe, that can happen, right? It's a bit rare, but definitely predominantly it's dominant, predominantly later in life presentation, and can is the predominant mutation present. Fine. Okay, great. Next. The moment you guys saw mesothelioma, you must have jumped, right? Mesothelioma is only one thing for us, which is asbestos exposure, right? Just few questions related to this. Coal exposure, or let's assume it's an anthracosis. Coal workers pneumoconiosis, right? Coal workers pneumoconiosis, will it increase the risk of cancer? Yes or no? Coal workers pneumoconiosis and cancer. Yes or no? Coal workers pneumoconiosis, there's a no increased risk of cancer. They will cause lung failure, interstitial lung disease, pulmonary failure, but will not increase the risk of cancer, right? And by default, I need not repeat, the most common cancer with asbestos exposure is lung adenocarcinoma. Most specific one is mesothelioma. Silicosis, will it increase the risk of cancer? Yes or no? Yes, silicosis will definitely have an increased risk of cancer, but not on coal workers pneumoconiosis. Fine. Okay, adenocarcinoma by default it will increase. Fine, perfect. Okay, next question. This is clue here. Spike and dome appearance, classical finding of membranous glomerulonephritis. What's the antibody seed? Sorry. What's the antibody seen in case of a membranous glomerulonephritis? It's your, sorry for that, PLA2R, PLA2 receptor. Sorry. Fine. It's IgG against your PLA2R. It's phospholipase A2 receptor. What's the deposit in case of a membranous glomerulonephritis? Subendothelial, subepithelial, or intramembranous? It is definitely subepithelial electron dense deposit, right? What is the immunofluorescence in case of membranous glomerulonephritis? Linear, granular. Thank you, sir. It is granular, right? It has to be granular, which is the only linear positive disease. There's only one glomerulonephritis which can have linear positivity in case of an immunofluorescence. There's only one disease which can have linear, which is Goodpasture syndrome. Only Goodpasture syndrome can have linear. Rest every glomerulonephritis by default has to be granular only, right? IgA will be mesangial, not linear. Okay, perfect. Next. Answer. Tell you a female with history of pyoderma 2 weeks back was investigated and she had an elevated creatinine. 3 weeks later, creatinine went up. Electron microscopic finding. Okay. First thing, if this option, let's say option B, had a break in basement membrane, will it change or not? Will the answer will still be the A, or will change the answer? No, it will still be A, right? Because the classical case of PSGN, right? I want to reiterate this point because twice this type of question was asked. After some time, there's a change in the creatinine level. Let's say today my creatinine is 2 milligram percentage. If it changes within 2 days, to let's say 4 or 5. Can I call this rapid or sudden? Within a couple of days, 24 to 72 hours max, if I have double the amount of creatinine, I think of an RPGN. The same 2 milligram creatinine in let's say 2 weeks, it goes to 5. I don't think of an RPGN here. It could be just a chronic renal failure. It could be just a renal failure, that's all, right? So it's a sudden onset, I think of an RPGN, then my answer will be break in the basement membrane. But here the question is 3 weeks later. If it's weeks, let it be even 8, I don't care. It will not be RPGN, it has to be days, only then it has to be RPGN. If it's weeks, it's not, right? It has to be a subepithelial deposit. Here diagnosis, classical PSGN only, fine? Great. Next. Which of the following is diagnostic in case of a Graves' disease? Great, it has to be an antibodies to TSH receptor, anti-TSH antibody, or we call it TSI. Thyroid stimulating immunoglobulin. This antibody actually sits on the receptor and acts like thyroid and activates the TSH receptor. Almost every antibody we know will destroy it. This will activate it, right? Where do you see anti-TPO? We see in case of Hashimoto's thyroiditis, right? Where do you see anti-endomysian? Thyroglobulin also can be seen in Hashimoto. Endomysian, case of celiac disease, right? Yeah. Endomysial antibodies to your, right? See in case of celiac disease. Celiac disease, what are the other antibodies seen apart from endomysial? You have anti-gliadin antibodies and you have anti-tissue transglutaminase antibody, right? Since we had celiac, yeah, DQ2, DQ8 as well. Can anyone tell me what is the skin manifestation which can be seen in celiac disease? It's a very classical skin manifestation which is your dermatitis herpetiformis, right? The reason for dermatitis herpetiformis is this anti-endomysial antibody cross reacts with the skin antigen, which destroys the skin antigen, which causes dermatitis herpetiformis, right? It's all due to the antibody. That's how it is. And this dermatitis herpetiformis will be seen only during the active episode of celiac. It will not be seen in case of resting phase of celiac disease, right? Perfect foothill. Okay, next. Okay, footprints on hand. Great. It's fluid overload, right? See, there are two things which keeps coming in case of transfusion: TACO versus TRALI. Okay, TACO versus TRALI, more or less they have kind of similar findings. Both will involve lung, both will involve within 6 hours of transfusion, everything will happen both in TACO and TRALI, right? I want you to remember 2 points which can help me to differentiate TACO or TRALI. Okay, which will have hypotension, TACO or TRALI? Hypo, less. Here it's fluid overload is TACO, right? TRALI will have, I'll come to your question, Jane. TRALI will have hypotension, TACO will have elevated hypertension, right? I'll have elevated BP here, you'll have hypotension here. That's one classical finding can help to differentiate them. Which of these two will have fever, TACO or TRALI? Fever will be present in case of a TRALI. There will be no history of fever in case of a TACO. But both lung can be involved. Though basal crepitation is more in favor of TACO, can be seen in TRALI as well at some point of time, right? Because TRALI is an activation of WBC, induced lung damage. TACO is fluid overload, induced lung damage by default, right? See here, I will not be able to pick up the most common cause of death. It could be anything. It could be it's a cardiac patient, right? So heart can also fail, which can also result in TACO. Yes, Ishan, TRALI is almost equivalent to like an ARDS, right? In case of massive blood transfusion, the most common cause of death is in dilutional coagulopathy, fine. Okay, fine. So that's regarding this. We think we have discussed close to 40 MCQs. Few common PYQs which has come in the last 2-3 years of NEET PG papers, fine. So all the very best. Sahil, it's a pulmonary edema. So whatever you see in features of pulmonary edema, you will see that in TACO, fine. Trial will have the reticulopathologies like in case of any case of any ARDS, right? All the very best. Do very well. Be patient. If you have not changed your sleep pattern, right time to change. Don't delay it. You have hardly 10-15 days. Change your sleep pattern and do very well. Fine. The PDF of this will be in the PW Med Telegram channel. I'll just push it across. So all the very best. Okay. Great. Fine. Ishan, I'll put a post, an easy way to remember on Insta very soon. Fine. Yeah. Thank you, sir.